Welcome to our video on pleural effusion and pleurisy. Let's get started. Here's our overview slide. Let's begin by discussing pleural effusion. Pleural effusion refers to a condition where there is increased pleural fluid in the pleural cavity. It can be generally divided into transitate and exudate. Pleural effusions occur as a result of the increased accumulation of fluid in the pleural space, secondary to changes in hydrostatic pressure, oncotic pressure, and/or capillary permeability. Let's discuss this in more detail on the next slide. Here's an excellent image courtesy of Amboss, which highlights several important features of pleural effusions. Notice that this image highlights the pathophysiology of transitive and exudative pleural effusions compared to normal. Normally, hydrostatic and oncotic pressures are in equilibrium, and capillary endothelial cells are preserved. However, in transitive pleural effusions, there is a net fluid accumulation in the pleural cavity, which occurs due to increased hydrostatic pressure and/or decreased oncotic pressure. Exudative pleural effusions occur as a result of increased capillary permeability due to damage, which causes fluid, protein, and cell leakage into the pleural cavity. Examples of conditions that can cause transitive pleural effusions include congestive heart failure, cirrhosis, nephrotic syndrome, and pulmonary embolism. Examples of conditions that can cause exudative pleural effusions include infections like pneumonia and TB, malignancy, autoimmune diseases, a chylothorax, hemothorax, and a pulmonary embolism. Note that pulmonary embolism can cause a transitive pleural effusion in around 20% of cases and an exudative pleural effusion in around 80% of cases. So remember that a pulmonary embolism can cause both transitive and exudative pleural effusions. Okay, moving on to the presentation. Patients with pleural effusions can be asymptomatic, especially if the effusion is small, specifically less than 300 milliliters. Symptoms such as pleuritic chest pain and dyspnea can also be present. Patients may have symptoms associated with the underlying disease, such as edema due to salt and water retention if they have congestive heart failure. Pleural effusions can be suspected in a patient with history and physical exam findings suggestive of effusions. These include decreased breath sounds over the affected area, dullness to percussion, and decreased tactile fremitus. Imaging, namely chest X-ray, is the best initial step in patients with suspected pleural effusions. It can detect as small as 250 to 300 milliliters of effusion. Typical X-ray signs supportive of effusions include costophrenic angle blunting, lung opacification, and even tracheal deviation in large effusions. Ultrasound can be used in trauma as part of the FAST protocol and is relatively sensitive. Here's a chest X-ray of a pleural effusion as seen on a lateral upright chest X-ray. Notice the opacification in the middle and lower lung lobes due to the effusion. Here's another chest X-ray of a patient with pleural effusions due to metastatic breast carcinoma. Notice the blunting of the costophrenic angle as well as the lung opacifications. Here's another chest X-ray of a patient with a small left-sided pleural effusion due to left lower lobe pneumonia. And in this image, you can see the blunting of the costophrenic angle, which is the area of the image that's circled. After imaging is done, a thoracentesis should be done, and on boards is often the best next step after a chest X-ray. Thoracentesis, also called a pleural tap or needle thoracotomy, is an invasive procedure where a needle is inserted into the pleural space. It's both diagnostic and therapeutic, as the pleural fluid obtained can be sent for analysis, and the fluid drainage itself will oftentimes relieve the patient's symptoms. A thoracentesis is indicated in any new unilateral effusion that is greater than 1 centimeter in size. It's not done in bilateral effusions or if there are clinical features of congestive heart failure. This is because the cause in that case would be very suggestive of pleural effusions due to CHF. Keep in mind that a thoracentesis can cause a pneumothorax as a complication, and this occurs if the lung is punctured during the process. Pleural fluid analysis is an essential part of diagnosing pleural effusions and identifying the exact etiology. It helps determine whether it's a transitive or exudative effusion. Many things in the fluid can be measured, including LDH, the pH, triglycerides, glucose, and amylase. The pleural fluid can also be sent for cytology, microbiology, cell count, and differential. A very important criteria you need to know for the boards is Light's criteria. If any one of these criteria is present, the fluid is determined to be an exudative pleural effusion. Let's take some time to understand this. The first of these criteria is a pleural protein to serum protein ratio of greater than 0.5. The second is a pleural LDH to serum LDH ratio of greater than 0.6. And the last is an LDH of more than 2/3 the upper limit of normal serum LDH. Here's a table that compares and contrasts transitative and exudative pleural effusions. Other than Light's criteria that we just discussed, on gross appearance, transitative pleural effusions usually have a clear appearance. The pH ranges between 7.4 and 7.55. The glucose content of 60 milligrams per deciliter or more, and an LDH less than 200 indicates a transitative pleural effusion. Exudative effusions may grossly appear milky in chylothorax, bloody in hemothorax and malignancy, and purulent in empyema. The pH of exudative pleural effusions is usually less than 7.3 to 7.45. A glucose content of less than 60 indicates an exudative effusion. This is because low glucose content indicates the presence of bacteria which consume the glucose in the fluid. An LDH of more than 200 indicates an exudative effusion. This may seem like a lot, but this is actually very high yield, so I highly recommend that you memorize this information. All right, let's try a question. A 61-year-old man comes to the physician due to increasing shortness of breath. He has been having a chronic cough and fatigue for the past year and has lost 4 kilograms in the past 5 months. He has smoked 2 packs of cigarettes daily for the past 35 years. Physical exam shows a thin, pale man. There is decreased breath sounds, dullness to percussion, and decreased tactile fremitus on the right lung base. Chest X-ray shows a right central lung mass, blunting of the right costophrenic angle, as well as opacification of the right lower lobe of the lung. What is the best next step in the diagnosis of this patient? All right, so this man is presenting with symptoms of pleural effusions supported by the physical exam and imaging findings. He has decreased breath sounds, dullness to percussion, and decreased tactile fremitus on the right lung base, which are classic exam findings of pleural effusions. His chest X-ray revealed blunting of the right costophrenic angle, as well as opacification of the right lower lobe of the lung, which again further indicates a pleural effusion. Therefore, the best next step in this patient's diagnosis is a thoracentesis. The patient's smoking history, chronic cough, weight loss, and a central lung mass make lung cancer the most probable underlying etiology of this patient's pleural effusions. Nevertheless, a thoracentesis needs to be performed for pleural fluid analysis. All right, moving on, for the next couple of slides, we're going to discuss specific etiologies of exudative pleural effusions. These include hemothorax, chylothorax, and malignant effusions. Let's first discuss hemothorax. Hemothorax, as the name suggests, is the presence of blood in the pleural space. This can be due to traumatic or non-traumatic causes. Non-traumatic causes include pneumothorax and malignancy. Key clinical features of hemothorax to be aware of include symptoms of the underlying disorder like signs of shock due to hemorrhage, such as hypotension and tachycardia. Characteristic pleural fluid analysis findings include bloody fluid and a red blood cell count of more than 5,000 cells per microliter. Lab analysis may show a low hematocrit, which is suggestive of bleeding. Hemothorax is always drained as has a high risk of complications and progressing to empyema, which we'll discuss later. Okay, now let's discuss chylothorax. This refers to chyle in lymphatic fluid in the pleural cavity. It usually occurs due to trauma to the thoracic duct or malignancy, which can lead to invasion of the lymphatics and leakage into the pleural space. Fever and chest pain is usually absent, which will be present, for example, in effusions due to pneumonia. Pleural fluid analysis suggestive of a chylothorax includes a milky fluid with high lipid content, such as high triglycerides and cholesterol content. Specifically, triglycerides of greater than 110 milligrams per deciliter is highly suggestive of a chylothorax. Next, let's discuss malignant effusions. These occur as a result of cancer-related destruction of the capillary walls in the lung and the pleura. Lung cancer, breast cancer, and mesotheliomas account for the majority of the diagnosed underlying causes of malignant effusions. Key features include symptoms of underlying cancer, such as cancer-related cachexia. Classical findings on pleural fluid analysis include a cloudy, bloody fluid with tumor cells, low glucose as they're being consumed by the rapidly dividing cancer cells, and high LDH levels. Next, let's discuss some complications of pleural effusions, which include parapneumonic effusions, empyema, and recurrent effusions. Remember, these are extremely high yield for the boards. So with this in mind, let's begin with parapneumonic effusions. Parapneumonic effusions are exudative effusions that occur in response to pneumonia. It can be uncomplicated or complicated. It's very important to be able to distinguish these from each other, as well as from empyema, which we'll be discussing shortly. Uncomplicated effusions have no bacterial invasion. In complicated effusions, the infection extends to the pleural cavity. Parapneumonic effusions will present with associated systemic signs of the underlying infection, such as fever, chills, and cough. The pleural fluid analysis will show a clear or cloudy fluid with a high white blood cell count. The gram stain in culture will be negative. Pleural fluid analysis suggesting complicated parapneumonic effusions include a pleural fluid pH of less than 7.2 and decreased glucose of less than 60. Uncomplicated parapneumonic effusion is treated with systemic antibiotics only. Complicated effusions are treated with systemic antibiotics plus chest tube drainage. All right, now let's discuss empyema. Empyema refers to the presence of pus in the pleural cavity and is a result of an infected pleural effusion. Common causes include pneumonia and an infected hemothorax. Fever and chills will be present. The pleural fluid analysis will show a pH of less than 7.2, very low glucose, less than 30 to 60, and most importantly, positive gram stain in culture. Empyema is treated like complicated parapneumonic effusions with systemic antibiotics and chest tube drainage. Here is a table that compares uncomplicated and complicated parapneumonic effusions as well as empyema. We just covered all of this information, but this table is here for you to review. The general management of pleural effusions includes treating the underlying cause such as pneumonia or CHF. Patients in severe respiratory distress need to be stabilized with supplemental oxygen, and therapeutic thoracentesis could be considered to relieve the patient's symptoms. Surgical options include a tube thoracostomy for emergent cases, such as penetrating trauma. Pleurodesis is a procedure where the two layers of the pleura are medically fused together and can be performed for recurrent effusions and for effusions non-responsive to treatment. All right, let's try another question. A 60-year-old man is brought to the emergency department by his son due to malaise and altered mental status. He has had a productive cough and fever for the past 4 days and has been treated with antibiotics, but his condition got worse. Lung auscultation shows decreased breath sounds, crackles, and decreased percussion over the right lung base. A chest X-ray shows a right pleural effusion. Pleural fluid analysis shows a cloudy fluid with a pH of 7.3, glucose of 45 milligrams per deciliter, and an LDH of 245 units per liter. What is the most likely underlying cause of this patient's condition? All right, so this is a 60-year-old man presenting with systemic symptoms of an infection, most likely due to a parapneumonic effusion. He's presenting with malaise and altered mental status in the setting of a productive cough and fever, which is suggestive of pneumonia. Lung auscultation also supports the diagnosis of pneumonia and shows decreased breath sounds, crackles, and decreased percussion over the right lung base. Pleural fluid analysis with a pH of 7.3, glucose of 45, and an LDH of 245 indicates an exudative pleural effusion. Parapneumonic effusions are exudative effusions that occur in response to pneumonia. Remember that exudative pleural effusions typically have a pH of less than 7.3 to 7.45, a glucose of less than 60, and an LDH of greater than 200. So in answer to the question, the patient most likely has a parapneumonic effusion. All right, now that we've discussed pleural effusion, let's discuss our last topic, pleurisy. This is another term for pleuritis or inflammation of the pleura. It most commonly has a viral etiology and may occur with infections such as Coxsackie virus, adenovirus, and influenza virus. It can also occur in the setting of inflammatory diseases such as lupus and rheumatoid arthritis. Drugs like amiodarone and bleomycin may also be responsible. It presents with a sharp pleuritic chest pain, and a pleural friction rub can be heard on lung auscultation. The diagnosis is clinical, and X-rays are usually normal or may show signs of the underlying disease. The treatment consists mostly of painkillers and NSAIDs, which are considered the first line. All right, let's wrap up with the final question. A 26-year-old woman presents to her physician due to chest pain. She says the pain worsens on deep inspiration and when she coughs. Her history is significant for influenza 4 days ago and an appendectomy at the age of 11. Physical examination reveals chest pain that improves with sitting up and leaning forward and worsens on deep inspiration, and a pleuritic friction rub is heard on lung auscultation. Otherwise, the rest of the exam is normal. Laboratory tests, including D-dimer, are normal. What is the most likely cause of this patient's condition? All right, so this patient has pleuritic chest pain which is most likely due to viral pleurisy caused by our influenza virus infection. Pleurisy is a clinical diagnosis and is typically suspected in patients with classical pleuritic chest pain, a pleuritic friction rub, and a supportive history. Remember that pleurisy is most commonly associated with viral infections, but can also be due to inflammatory diseases such as rheumatoid arthritis and lupus, as well as drugs like amiodarone and bleomycin. So again, the answer to the question is pleurisy. And that concludes this lecture.